Two, one. We are live now.
Very good evening, all. We welcome on behalf of IPCA to this series of webinar where we are discussing on different aspects of disease management. So, on the eve of Hypertension Month, and you already know that 17th was World Hypertension Day, we are discussing about the management of hypertension and different aspects related to hypertension. So, today, on continuing with the same, we have one of the most eminent speakers from Rajasthan, Dr. Kushwendra Parashar, who is a MD and DM cardiologist, interventional cardiologist from SMS Medical College, Jaipur. He is currently a director of Parashar Health Clinic and Jotabar, Jaipur, and also a director and head in Marudar Hospital and Sparsh Hospital. He will be today speaking on the common mistakes in the management of hypertension, and he will be enlighten us on the treatment and other aspects related to hypertension. So the flow will be like that. Sir will be presenting on this, and later we'll be taking the queries from the audience, if any. So, not taking much of the time, I hand over the session to sir and welcome Dr. Parashar on the dial. Please, sir.
Thank you and good evening. And today my topic is common mistake in management of hypertension. Come to the introduction. Hypertension is the most common and important preventable condition seen in primary care and lead to myocardial infarction, stroke, renal failure, and death if not detected early and treated properly. About the global burden of hypertension in 2000, 26.4% of the world adult population had hypertension, but it's estimated to be 29.2 in 2025. Total burden of the hypertension in adult was 972 millions worldwide, but it is seeming to be increasing approximately 60% overall and 24% developed country and 80% developing country. This is a high marker for us that the increase in hypertension in developing countries like Asia and Africa is going more. But initially it was seen that the hypertension were more prevalent in the developed countries like North America and Europe. What the Indian scenario? What the mistakes made by the patient level? Myths. Hypertensive are symptomatic. So most of people think that whenever he or she have the hypertension, he or she should have some symptoms. But most of the patient, approximately 90% of the patient with hypertension have no symptom when they come to in contact with the physician. Another myth is the hypertension is disease of elderly. The most of people think that hypertension start after the 40 or 50 of the age. How it can be possible in the adult or young patient? But the fact is there is no age limitation for the hypertension. At any age, hypertension can occur. Another myth is the once diagnosed, start drugs. Now people think that when we go for the physician, they diagnose hypertension or they immediately start the treatment. But as a physician level, we should first fact is the evaluate for the secondary hypertension causes. There are the curable causes, some causes are curable, and then rely on the stress on lifestyle modification. The lifestyle modification can decrease or can delay the hypertensive treatment. Another myth is the stop drug once BP is normal. The people think that my BP is controlled by this drug, and now I'm okay, so I should stop that drug. But it is very wrong. Hypertension is a controllable disease, not curable. And when the person stops the medication, again, there are more chance of the side effects of the hypertension. Another myth is the regular intake of drugs can produce side effects. The people think if they continue their medication, they have a lot of side effects. The English medicine has a lot of side effects. But the fact is, uncontrolled hypertension produces end organ damage. End organ damage means irreparable damage or irreparable loss of the kidney, heart, brain, and peripheral tissue. So now come what the common mistake they make in the management of hypertension at the physician and patient level, both. The major causes of the inappropriate management of hypertension are the inappropriate measurement of blood pressure. Any faulty technique of blood pressure, we will later discuss about this. Incorrect diagnosis made at the physician level. Medication that are contraindicated in specific disease as prescribed by the physician. Given monotherapy Patient was taken on the monotherapy, but actually it's required combination therapy for proper control of the hypertension and lack of adherence, especially in elderly population. The inappropriate measurement of BP. What is the impacts of that? Overestimation of blood pressure. Overestimation of blood pressure by just 5 mg can lead to inappropriate treatment of approximately 30 million patients. An unnecessary treatment cost, treatment diagnosis, potential side effect of the medications, and mislabeling as hypertension which lead to psychological trauma to the patient and psychological issues may occur in few patients. So unnecessary overestimation of blood pressure is dangerous. The underestimation of blood pressure. If we mislevel underestimate blood pressure by 5 millimeter of mercury, it will lead to mislevel of approximately 20 million of patients. If with the pre-hypertension when they would have pre-hypertension. If we are not treating the hypertension, then they lead to end organ damage. So if we these are incorrect diagnosis or underestimate blood pressure, at least like 5 mg, having the later impact of the damage by stroke, kidney damage, and heart failure. What should be the ideal cuff size? How we can measure the correct blood pressure? The ideal cuff size is very important in this thing. The ideal cuff size should have the bladder length that is 80% and width of the bladder at least 40% of arm circumference. This is the measure by the bladder, not by the total cuff size. The measure cuff. So the bladder inside the cotton materials are wrapped around. The bladder length and its width is the most important thing. The most present is cuff have an index marker and range marker which can assist in preventing miscuffing without the need for measuring the arm circumference. Once the index marker is within the range, the cuff is of appropriate size for the patient. There are EC, C and AHA recommendation for the arm circumference and cuff size. If the arm circumference is 22 to 26, that is known as a small adult cuff. The standard size 27 to 34 centimeter arm circumference and adult size cuff should be taken. If there is a 35 to 44 centimeter of the arm circumference, then large adult size cuff should be used. And if the arm circumference is 45 to 52 centimeter, then adult thigh cuff size cuff should be used for that. 6 common mistakes can lead inaccurate elevated BP reading according to AHA. These are the most important things. Poor sitting posture. Patient should be seated in proper position with supported arm. So most of the patients sometimes we are hanging arm. The support of arm is very important. Arm at the level of the heart is another point. Wrapping the cuff over the clothing. The cuff should be wrapped around over the bare arm, and it means the clothing should be removed from the arm. Then cuff should be used. A cuff that is too small for your arm. If the cuff is too small size, then overestimation of the blood pressure may occur. And during the BP, patient should be silent and cool and calm. So no talking about with the patient having a full bladder. The full bladder have also irritated the sympathetic activity, so that it leads to high blood pressure. The patient should be comfortable sitting, no leg crossing. So the patient should not have the leg press, hanging the legs comfortably or touch with the touching ground, not hanging. Or we should measure in the lying down position. Incorrect diagnosis bring more complication. How? A misdiagnosis could result in delayed treatment. This may cause other complication or more severe illness that may be irreparable loss. An inappropriate follow-up plan was one of the common reasons for misdiagnosis. And reason for inappropriate follow-up includes lack of follow-up, incorrect interval for follow-up, and no documentation follow-up. So follow-up guidelines should be proper with the proper time interval, and everything should be noted on sheet so we can rely upon, or we can make use of the drugs properly. We add on the drug or decrease drug, or add on addition of the newer drug, or if we have drug having a side effect, then addition of the another group of drug. This is the taxonomy for the hypertension diagnosis and management. The two type of diagnosis problem and the treatment problem, and the diagnosis and hypertension diagnosis, misdiagnosis. It means patient systolic blood pressure is less than 40 and diastolic blood pressure is less than 90, and hypertension diagnosis is made and there is no history of hypertension diagnosis or no history of anti-hypertension medication. Another is the incomplete diagnosis, hypertension diagnosis and no record of blood pressure. or no record means that no previous history, no measuring of the regular interval, or no any target organ damage should be mentioned about that. So we can rely upon the diagnosis. No hypertension diagnosis made in spite of the patient blood pressure was more than 140, systolic BP and diastolic blood pressure 90 or more than it. And no hypertension diagnosis made. If there is hypertension, patient should be go for lifestyle modification or treatment proper time. Another is the intervention by the physician. Omission of essential like medication. Patient diagnosis was made. Hypertension was there, but no anti-hypertension medication was prescribed, or no history of use of anti-hypertension medication was taken. Sometimes patient come to your clinic without any medication, and blood pressure was normal, but patient was already on anti-hypertensive. You assure him that you are okay, the BP is normal, so nothing to do. But the patient was hypertensive. These mistakes should be taken upon. Another patient teaching. Hypertension diagnosis with the CSVP more than 120 mmHg and diastolic blood pressure 80 mm mercury, and no lifestyle modification was prescribed. Patient if in the pre-hypertension the lifestyle modification should be started, and patient teaches about the regular checkup and blood pressure and drugs. Follow-up anti-hypertension medication is prescribed, but follow-up is not documented. Patient we prescribe hypertension medication and not given for the time limit. Come for the next visit for the 1 month, 2 month, whatever. So follow-up is very important to measure the blood pressure in proper level. And another intervention contraindication. Medication, anti-hypertension medication, contraindication for stress disease prescribed should be taken upon. What we are prescribing for the patient if this group is right for that patient. If the patient having the contraindication for the AC, contraindication beta blocker, there are many of the contraindications or reduce the number of pills. So what things should be taken in mind when we are prescribing the drugs? And no drug, any drug should be prescribed with that as contraindication. Error encountered in hypertension management. In terms of error related to hypertension management, the rate of error of omission for medication as well as for patient teaching was higher than that of inappropriate treatment. It means the wrong medication are very rarely prescribed by any physician level due to the lack of the history taking, but at the patient level, patient teaching, lifestyle modification, how to take drugs, which time we should take drugs, then usually omitted. And the medication errors are the most frequently reported type of error by healthcare provider, and omission of the medication is the most frequent type of error. Sometimes the patient come, take the medication, come to the clinic, the blood pressure is normal. But when patient visit the clinic, he omitted the drugs for 1 or 2 days, and the patient blood pressure is so high, and then the physician add on another drug, and then when patient take medicine, the blood pressure is low. The proper follow-up with the proper BP recording and proper follow-up data should be very important for the patient perspective. And BP pattern based on the office and out-of-office measurement. They are the normal tenses, sustained hypertension, or masked hypertension, and white coat hypertension. They should be differentiated for the patient prognosis. Prognostic view. Normal tension means office, clinic, healthcare setting, and home or ABPM, both blood pressure are normal. Sustained hypertension, home as well as office, both blood pressure are raised and mean hypertension. And then we should differentiate between masked hypertension and white coat hypertension. And these can be diagnosed by the ABP, ambulatory blood pressure monitoring. The masked hypertension means office or clinic blood pressure is normal, but home or ABPM setting there hypertension is diagnosed. In the white coat hypertension, when patient visit to home, clinic or office, that blood pressure is elevated, but at the home or ABPM monitoring, there is no hypertension diagnosis. So these two taken in account because of the prognosis effect and the long-term impact on the life and mortality as well as morbidity. Medication contraindication specific condition. We should check which medication should not be given in this condition, like diuretic. The diuretic compelling contraindication is the gout, which increases uric acid level, and possible is the pregnancy. And it is useful in heart failure, elderly patient, isolated systolic hypertension, and a particular African origin of the hypertensive patient. Loop diuretic is more important than end-stage renal failure and congestive heart failure. Diuretics, anti-aldosterone, and potassium sparing diuretics is favoring for the congestive heart failure and post-MI, but contraindicated in renal failure and particularly patient with the hyperkalemia, and should also be avoided in the pregnancy. Beta blocker should be avoided in asthma, COPD, AB block, and perivascular disease, or patient with athletic or physically active patients. Calcium antagonists that are the dihydropyridine should not be given in tachyarrhythmia patient or patient with heart failure, but it is useful in elderly isolated systolic hypertension, angina, perivascular disease, carotid atherosclerosis, and pregnancy. They are among the few drugs which can be safely prescribed in the pregnancy. A calcium antagonist, verapamil and diltiazem, are very useful in angina, supraventricular tachycardia, and carotid atherosclerosis, but contraindicated in AV block, grade 2 or 3, or congestive heart failure. AC inhibitors should not be given in the pregnancy, patient with hyperkalemia, and bilateral renal artery stenosis. These are the similar contraindications for the angiotensin 1 receptor blocker. An alpha blocker should not be given with patient with the orthostatic hypotension and heart failure, but they are useful in hyperlipidemia as well as benign prostatic hyperplasia for the older people. Concept of anti-hypertensive medication contraindicated in specific disease. The physician error is very rare, but in this showing the beta blocker by prescribed frequently even in asthmatic. But we can't ignore the beta blockers benefit in the cardiac patient. So that's why that may be the reason they are prescribed beta blocker in the asthmatic also. But if there is reactive pathway disease, it should not be given. An AC inhibitor not given in the pregnancy and angioedema, as well as the ARVs, and as well as aldosterone sparing and corticosteroid diuretics. Given monotherapy, who require combination therapy? Blood pressure control rate are suboptimal with the monotherapy. More than 75% hypertension patients do not have adequate BP control with the monotherapy, and so they require the combination therapy. So the add-on therapy is very important. So, if systolic blood pressure is high, increase the first basic drugs dose and then add on the another drug, so that we can act on the two different receptor levels, so the more efficient blood pressure control can be achieved. Lack of adherence, especially in elderly. Lack of adherence is very important for the that is considered the pseudo resistance. Only 1 in 7 people with a raised blood pressure have it adequately controlled. It means only 15%, approximately 15% people having the controlled blood pressure. 1 in 4% on antihypertensive are not taking prescribed medicine. Approximately 25% people who are prescribed medication for the hypertension, but they are not taking. That is a huge burden. Adherence in elderly population is becoming a growing issue of concern. Reason for the non-adherence in elderly are decline in cognitive function. The mental status, sometimes people don't take medicine. Decline physical well-being. The physical well-being is not good, then the mental status is definitely deprived, and so sometimes they don't take the medicine. Multiple comorbidity, because of multiple comorbidity, there's an increased number of the medication. So we should always take upon the drug to be prescribed the minimum in number and maximum in dose. So the number of pills can be decreased, so the patient is get comfortable with that. And complex treatment as well. With the patient having the multiple disease, you have to take the multiple disease treatments. So we should take and educate the patient properly, and with a psychological training, and as well as counseling should be done. So patient take or adherence will be proper with the proper follow-up. If the patient going with the proper follow-up, most of the patient will adhere to the treatment. Hypertension is silent killer. The silent killer, natural hypertension, has an impact on patient adherence to treatment for the condition. Like many other non-communicable diseases, hypertension does not show sign of manifestation. The most of patients are asymptomatic until the serious systemic end organ damage that can appear after the years after diagnosis becomes symptomatic. When the patient symptomatic, patient present with a heart failure, kidney disease, stroke, MI, before the complication or before the target organ damage, by the proper timing, blood pressure diagnosis will be done, and patient should have the control blood pressure, so he can delay the morbid condition that can impact his life as the cost of the. For the impact, high impact of hypertension, more than 1 billion people globally are living with a blood pressure. And by the 2025, it is estimated 1.5 million people will have hypertension. The increase is more than approximately 60% in the hypertension burden in the 25 years. And thank you.
Thank you very much for your enlightening presentation. And I really, there are many points which I have given, which are really very common, but very commonly mistakes are made. On the same lines, sir, there are few questions which have came. So one by I'll ask those questions from you. The first question which came from Dr. Sandeep is, what is the factor that affect blood pressure measuring, and what are the mistakes commonly done?
As we have described in this prescription, basically patient when come to the clinic, we never take BP blood pressure immediately. At least patient should sit comfortably at 10 minutes. And when we measuring blood pressure, patient usually cross their legs on the sitting table. There should be no cross leg. Patient leg should be comfortably touching the ground, and the arm should be supported, not hanging around. And arm should be at the handle of the chair or at the level of the heart. And another thing is the proper cuff size. Cuff size should be proper. The most of physician, even cardiologist, everyone taking single cuff in use and measuring the blood pressure. Ideally, in the every clinic there should be three or four sides of the cuff that are recommended, and according to arm circumference, we should use the blood pressure cuff. So we can take the proper blood pressure measurement, and we should take at least 2 or 3 BP monitor readings, and then we can actually realize when we use the digital blood pressure instrument, they every time they give different reading. And if we are using digital blood pressure measurement, we should take 3 readings, then average should be taken. Or to put proper diagnosis, nowadays ambulatory blood pressure measurement monitoring is most important. Ideally, every patient should have the ABPM at the start of the diagnosis, and then the follow-up for the proper treatment patient is properly going on or not. Sometimes like the patient having clinic BP is normal, but then at home BP is high. So this can be only diagnosed by the ABPM. So the at least if the 6 month interval ABPM should be measurement should be done. So we can provide the patient, some patient having the night BP high, some patient the morning BP high. So we can know the what is the normal dipping, what is the high dipping. So we can give the proper timing of the medication drugs. Some people in the night time high BP, so we prescribe the evening blood pressure. Some people have the morning high BP, so we prescribe the medication in the morning. And the duration of the drugs, the half-life should be also taken. So with the measurement of the blood pressure, with the drug, everything should be taken around.
Thank you, sir. Second question came is that Remeripil can be used as a first line of treatment for the treatment of hypertension?
Yes, can be used, but the Remeripil is a very mild antihypertensive. So most of people use a 2.5 milligram, 5 milligram, but the most of trial even 10 milligram of the Remeripil in the with the blood pressure of 90 and the heart failure is used. So nowadays the use of Remeripil as an antihypertensive very rarely used, very less number of people are using it, but definitely this antihypertensive we can use it, and for the particularly young patient, they're very good for the hypertension. If a patient, some people respond very well with the Remeripil, and the long-term benefit for the decrease in the proteinuria. This is the major goal, to decrease the proteinuria and decrease the renal damage. So definitely a patient can tolerate without a side effect and blood pressure control, then we can use the Remeripil as a first line, because the first line, the ACARB, both are the first line for the antihypertension treatment.
Right, thank you, sir. One more question is that, sir, a patient says that my diet and I started doing exercise and now my blood pressure is controlled. So yeah, how to, because he's saying I have to worry anymore. What is the answer? Many people do like that.
Definitely. Ideally, every patient will come to naive hypertension. Naive means patient has not taken any medication ever for the hypertension and blood pressure is high. Ideally, lifestyle modification should be started first, and then patient taken for the follow-up. What treatment remain? If the patient on lifestyle modification for 3 months at least, patient get the blood pressure normal, then no need for antihypertensive. Lifestyle modification means low salt, less than 2.5 gram, high intensity exercise like at least 30 minutes of the brisk walk for the 5-day week, with the no alcohol, no smoking, and DASH diet, dietary approach to stop the hypertension. Dietary fibers, fruit, high amount of the vegetable, low dairy products and fish can taken, and nuts can also use, and high fiber diet. These are the commonly used lifestyle modification. They should be used first before the start of the treatment, And definitely, a patient is controlled with the lifestyle modification, never start the hypertension for the as a predictor that the patient requires in the future. No, patient should be taken in the follow-up as on medication and advise him to delay. If a patient any time patient has the hypertension, then should start the hypertension.
One more question is that, sir, what situations is the screening of secondary causes of hypertension is necessary?
Definitely. Ideally, every patient should be taken for the young patient, young adult, who are the hypertensive, should be screened out first the normal causes of hypertension, like the most common are the renal vascular diseases. Renal vascular disease should be ruled out first by the simple things, protein, urine protein, serum creatine, ultrasound for the kidney side, and the bilateral renal doctor. Then for why we go for the secondary causes are most common are the patient with the refractory heart failure, flash pulmonary edema, resistant hypertension. These are the more common causes. Resistant hypertension should be proper resistant hypertension. Means patient on the 3 medication with the, including 1 diuretic and in the proper highest maximum doses and still having the blood pressure and not in the control. In these conditions, we go for the search for the secondary hypertension. And we should first rule out the patient is actually is resistant hypertension. So there are the most common hurdle are that the patient has a pseudo resistance. Pseudo resistance means patient are non-adherent to medication. On the visit of patient with the doctor, patient not taken the medication for 1 day or 2 days, or missing the morning dose when comes to the clinic. So before establishing the diagnosis for the resistant hypertension, we should assure the patient is resistant hypertension, flash pulmonary edema, refractory heart failure, or the patient is going the renal failure. Then we go for the rule out the causes of like secondary hypertension, like the obstructive sleep apnea, obesity, Marfan syndrome, aldosteronism, Cushing syndrome, and the pheochromocytoma. These are the common causes for the secondary hypertension and thyroid disease that can be treatable. Or so definitely there are 3 or 4 indications for the secondary hypertension.
Thank you, sir. One more question is there, sir. Hypertension affects men, but women are rarely affected. What are the facts and what is the myth?
Yes. Patient basically in the young age, less number of female having the hypertension, and then the young adults male. This is due to the hormonal effect that the estrogen is protective, having the protective role in this. But after the 50 year, the number of the female is also exceeding or almost similar with the hypertension, and hypertension is giving the more complications in the female later on than the male, due to the less number lack of the adherence.
Okay. So, what is the drug of choice for the treatment of hypertension, primary hypertension particularly, sir?
Primary hypertension, basically, ideally the diuretic with the AC or ARB, the first line of drug. Then we can use the calcium channel blocker with the diuretic. If they are not controlled, then the AC, ARB plus calcium channel blocker and diuretic. And then the beta blocker are the basically not in the first line of the treatment. They are the only with a few compelling indications, like patient having the heart failure or MI or angina. In these cases, we can use the beta blocker as a first line with the 3 first line drugs with add-on therapy. But the AC inhibitor, ARB, calcium channel blocker like amlodipine, berendipine, the newer generation of the calcium channel blocker, and diuretic, definitely the other first line of the management team.
Right. So in beta blocker, which beta blocker is your choice, sir? Metoprolol, bisoprolol, or there are many beta blockers which are available.
Basically, the most of the trial coming with the bisoprolol and the metoprolol. And as an antihypertensive, bisoprolol is more effective. But initially, people were using the atenolol, but the most of trial not favoring use of the atenolol. So most of the patient have used the metoprolol as in patient cardiac diseases or heart failure or MI post patient. Or only if a patient has tachycardia, then we use the bisoprolol as a more potent hypertensive than the metoprolol.
Okay. And so, which is the
we also use the carvedilol, but not as a major antihypertensive treatment. Only as a heart failure patient, we use the high doses of the carvedilol also.
And which drug is more used in diabetic hypertensive as a first line therapy?
Diabetic hypertension, definitely ACE/ARB is the first line of treatment, and then the calcium blockers.
Right. So these are the few questions which came, sir, and with this we'll be closing the question answer session. Thank you very much, sir, for taking time out on Sunday evening. And thanks to the audience which has taken time out, sir. It's a good number of audience which is already logged in, sir. I'll be sharing the number with you also, sir. And it was really enlightening, and I'm very, very sure that this kind of discussion, which we are going to continue in future also, will be helping in the overall better treatment of the patients and controlling this silent killer, that is hypertension, sir. So from on behalf of IPCA, sir, I thank once again, thank you very much for taking time out, sir, and making this